talk will be on central serous retinopathy, and Dr. Raju is here. He will elucidate the recent understanding of CSR, that it's primarily a choroidal disease. Also, it is known as CSR retinopathy, but it's CSCR. And how should we practically approach these patients? Primary patients, recurrent CSR, bullous CSR, and I think Raju will take us through this journey. Thanks, Raju.
Very good afternoon. Thank you very much, sir, for giving me this opportunity in your IC. So, CSR is considered as the fourth most common non-surgical retinopathy associated with fluid leakage. And it was first recognized way back in 1866, and it was termed as central recurrent retinitis. However, it was Gas who explained the pathogenesis and explained the clinical features and named it as central serous chorioretinopathy. So let me start off with some spotters. Is this CSR? This is spotter number 2. Is this a CSR? Now, by history, how can we get some clues? So we all know that CSR is seen in middle-aged males, is painless onset of diminution of vision. They may complain of micropsia and they may have positive scotoma. So you should also ask a history of whether intake of any steroid medicines is there. But if you casually ask them, do you use any steroid medicines, they'll tell no. So we need to ask pointed questions. Are they taking any skin ointments? Are they using any inhalers or any other preparations? Then the patient may tell that I'm using some ointment for a skin allergy or so. Also assess the patient's personality. Does he have any Cushingoid features? And rule out pregnancy in a female patient. So a good history taking is important because we can identify the risk factors that are there for this patient, and a drug history. Even oral contraceptive pills can cause, various drugs used for cancer can cause CSR, and commonly used or drugs like sildenafil can also cause CSR. So a good history taking is important. Now coming back to this spotter, is this a CSR? Well, when we did an indirect ophthalmoscopy, this patient actually had a retinal detachment. You can see the attached and the detached retina here, and this actually turned out to be a retinal detachment, a rhegmatogenous retinal detachment with an inferior break. So if you don't do a good examination, you'll miss out on findings. So look for corrugated appearance. It could be a shallow retinal detachment. So it's very important that we do a good indirect ophthalmoscopy before ordering an OCT. So because differentiating a CSR from RD is important, because if we miss an RD, we are doing harm to the patient. So one should not make a diagnosis of CSR without being sure of the extent. Although it is important to rule out RD, we should not be under the impression that the CSR does not extend to the periphery, because rarely you have what is called as an atypical CSR, wherein it can extend to the periphery with multifocal detachments. This is a patient who presented with a diminution of vision since 25 days. He was treated as an exudative RD with steroids, and because he had a peripheral detachment. And when we did the FFA, we could see multiple pigment epithelial detachments, and this patient actually was a patient of a multifocal CSR. And all we had to do was to stop the steroids, and this patient did well. Coming to this spotter number 2. Now, whenever you see a patient whom you suspect as a CSR, make sure you have a look at the disc. This actually is a patient with optic disc pit retinopathy, and always make sure you have a careful examination of the optic disc whenever you suspect a CSR. Now, this is another patient who came with a sudden decrease in vision and was suspected to have a CSR. So what would be your next investigation? Would you do a OCT, would you do a FFA, or would you do both of them? Then commonly we would go ahead and do a OCT. What would you explain to this patient? Would you do observation, or would you go ahead and do FFA in this patient? Well, OCT was not the next investigation to do in this patient. The most important investigation was to do a good slit lamp examination, because a patient had retroenteral cells in this patient. So the next investigation, logical investigation, was FFA and B scan, and this patient turned out to be a case of posterior scleritis, and T sign was there on B scan. So this patient required a steroid. So this is not a CSR, this is a posterior scleritis. This is another patient who was suspected as CSR and sent to me. And when we did the FFA, the patient had a idiopathic CNVM. So these are the various differential diagnoses that one will face when you are seeing a patient of suspected CSR. This is another patient which can mimic a CSR, it's a PCV. So the typical FFA, we all have learned that ink blot appearance and the smokestack appearance on FFA. And chronic CSR, you will see these tracks. Autofluorescence is one more important tool that can help us to visualize the CSR and the various damage to the RP that it has caused. However, OCT continues to be the most important tool in managing these patients, as we can see the reduction in height and also reduction in the area of the CSR on on-face images. With the enhanced depth OCT, we'll be able to make out the increased choroidal thickness in these patients. Because right now, the CSR pathology is considered as a choroidal hyperpermeability, and the choroidal pathology is the reason for the fluid in the retina. Even the recent classifications, this is the recent classification by the international group, lays a lot of emphasis on the OCT here. We have classified the CSR into simple, complex, and atypical. And they are again further subdivided into primary, recurrent, and resolved. And if the SRF is persisting for more than 6 months, it is called as persistent. And both simple and complex can have with or without outer retinal atrophy. So this is the latest classification for CSR. So they are also classified and given the major criteria and minor criteria, and this lays emphasis on the OCT part. Coming to the treatment, so whenever you see a patient of acute CSR, the most commonly what we do is the conservative management and look whether the patient is highly symptomatic or is a recurrent episode or it's a bilateral disease activity. So if it is highly symptomatic, recurrent, then one may consider a treatment, active treatment, that is laser. So most important before you consider this treatment is to eliminate the risk factors, reduction of emotional stress, treating the anxiety and other things. Because most of our patients would resolve spontaneously. If at all we want to treat, we have to go ahead and treat with a focal laser, with the green laser for extrafoveal leak. However, if it is subfoveal, we may have to consider a high density subthreshold micropulse laser in these patients. This is a patient who was treated for the focal leak. You can see the reduction in the SRF. Usually by around 1 to 1.5 months, you will see the resolution happening. As far as the medical treatment is concerned, the two drugs that are commonly used are the spironolactone and eplerenone. However, they have very modest efficacy as far as improving the BCVA is concerned. And in this second study which was done, wherein it was studied in chronic CSR patient, it was not found superior to placebo. However, whenever you are using these drugs, you should, especially eplerenone, you should look out for hyperkalemia. So get a serum electrolytes tested in these patients. However, my experience has been good. This is a patient who came with a CSR which had a thick exudative fluid in the subretinal space, and this is after treatment with eplerenone at around 2 months' time or 3 months' time. This is another patient, same with an exudative CSR treated with eplerenone. So even in chronic CSR, it has been reported that these patients do well, but however, some patients may not respond. As far as antioxidants is concerned, again, they do not show any benefit with respect to visual acuity. However, they significantly reduce the subretinal fluid height. So there's a decreased chance of fluorescein leakage, and additional treatments required were less at the end of 3 months. As far as NSAID is concerned, there's very minimal role for use of nepafenag or any other non-steroidal anti-inflammatory agents. Let us come to some unusual situations in CSCR. One is in pregnancy. This is usually seen in the third trimester and usually resolves spontaneously after delivery. And most commonly you see exudative type of CSCR in pregnancy. Other condition is a sleep apnea syndrome that one may have to consider in these patients. And it is said that it can be seen in about 2/3 of the patients of CSR patients. The next entity is called as something that is very unusual. You heard it right. This is familial CSR. Familial CSR. So this, I had a patient in 2011 who presented with counting finger vision. And this was his presentation when he came to me with a bilateral exudative detachment. When we look back his FFA in 2008, he had features that were suggestive of a CSR. What we had to do was, he was put on steroids by somebody else. We had to just stop the steroids, and after that, he improved. But one interesting development that happened was the patient's sister came for a routine checkup. She had a 6/6 vision. She had some pigmentary changes. For that, she was referred to me, and we did the OCT. We could see shallow fluid, and the FFA revealed small PEDs. So when I went back and searched the literature, actually there is a condition called as familial serous retinopathy that has been described way back in 1996. So very rarely one may have to consider these differential diagnosis. To conclude, CSR is a commonly encountered disease in day-to-day practice. Understanding the etiologies, differential diagnosis, and various presentations will help us in managing these patients better. Thank you very much.
Nice presentation. Any questions from the audience? So first thing, for the benefit of the audience, how long will you wait for any kind of invasive laser or anything? How long will you like to wait before going in for any kind of treatment?
As I said before, in my patient, I usually wait for 3 months. So for 3 months, I just communicate to the patient that to reduce their stress and look for other risk factors that they have and try to address those stress. And at the end of 3 months, if they still have the fluid, I monitor them on monthly basis on a OCT. And if they still have fluid, then I would consider any other treatment in these patients.
So one thing, you can define CSR as an acute CSR, and you can define CSR as an chronic CSR.
Chronic CSR.
And the treatment of acute CSR is just observation, and chronic CSR, you have to go for a multiple modalities of treatment, what Dr. Raju has mentioned. You have a question?
Yeah.
Then,
Good afternoon, everyone. Do you have any experience with melatonin in CSCR?
Sorry?
Do you have any experience with melatonin in
it's been
CSCR?
reported, but personally I have not had an experience. It's been reported with skin usage for the skin treatment, right? But sometimes they may have a combination of treatments. That's the other thing that we have to look at. So I usually ask the patient to get the drugs and the ointments to me next time when they come, so that we look at what are the contents of the drugs.
So, Raju, when do you start Apilnon? When you mentioned that many patients, I have a good experience with Apilnon. So which patients you take up for this drug?
For?
Apilnon.
So those patients at the end of 3 months, or if they're presenting to me with a 2 months or a 3 month history, wherein they already have waited for 2 months or 3 months with another doctor, at that time, and if I see the fluid is, as I showed you in my presentation, the patients with thick exudates, in those patients, I directly try to consider Apilnon.
Hello everyone.
Sir, is there any role of serosiopeptidase in CSR?
Role of?
Serosiopeptidase?
No, ma'am, not that I'm aware of.
Sir, any correlation between hair dye and development of CSR?
No.
Patient using hair dye and after he develops CSR?
No, not that type of.
I have seen few patients which used hair dye, and after 10 to 1 week or 10 days, they complain of diminution of vision, and we diagnose the CSR. That's why.
One thing you should always ask whether they are using any skin creams which contain steroids or not. If there is any history, then you should ask these patients to stop skin creams with steroid because that is known to cause CSR or worsen CSR. But as per literature, we don't have any correlation between hair dye and central serous retinopathy.
Okay, thank you.
Nice
Sir,
talk, Dr. Yeah.
sorry. So, is there any role of carbonic anhydrase inhibitors, oral or topical, in the treatment of CSCR?
No, no, ma'am.
Dr. Raju, nice talk. I had two questions to ask. One, how is your approach different when you're dealing with very fibrin kind of a CSR? Number two, do you consider using maybe a strong anti-VEGF when you are typically dealing with a pachychoroid kind of how do you take that as a treatment option?
No, as far as exudative is concerned, as I mentioned before, if it is very thick exudate, I consider eplerenone right from the beginning in those patients. And in the pachychoroid, unless there is a CNV, I would not consider an anti-VEGF in these patients.
So what's your take? What do you, sir?
Shall I?
Yeah.
I have a question. So a patient comes to me, an acute CSR, and the leak is extramacular, simple CSR, and we just wait, try to figure out the if he has stress or anything, steroids, and we wait normally, and in a month or 2 months it goes away, fine, it resolves. But we find that although the CSR is gone, but there are some fine hard exudates in the macular region because we waited about 2 months for the fluid to go away, and now the patient's vision is 6 by 6, but little less, and the contrast sensitivity has gone down a little bit. Now, I wonder that what would have happened if I had treated, because it's an extramacular leak away, if I had put in a few spots of laser like 4 weeks after and prevented that hard exudate forming and the contrast sensitivity going down, because for life his contrast sensitivity is gone. What's your comment?
As far as I am concerned, I usually treat it at 3 months. But having said that, whenever the resolution of the fluid is very fast, then also the hard exudates can still form, what you're telling. So at the end, what are the previous experience is that whether you do early laser or late laser, the final visual outcome turns out to be the same. That's what we have learned from experience and literature. Thank you.
One thing about the exudates, what you are calling are subretinal precipitates. That yellow things what you see, these are subretinal precipitates and they go with time. You don't need to treat that. Second thing about contrast sensitivity, once the fluid disappears, the contrast sensitivity comes only by 3 months. Patient complains that there is a decrease in vision, but the contrast sensitivity comes by 3 months. With this,
one thing, sir, here.
I'll ask Dr. Ritesh Narula to put his talk on the dais, and he's a consultant at LV Prasad Eye Center, and he'll be talking about other most or must know macular disease, that is diabetic macular edema. By the time somebody was asking
Here, sir. If we find hard exudate in CSR, probably we are dealing with some other pathology. There's some other pathology going on. Generally, hard exudate doesn't seen in CSR cases. Maybe something else we are dealing with.
Yeah, Raju, will you like to answer this? Look, if you have an hard exudates, then with a serous kind of a detachment, my most likely diagnosis will be PCV.